we have a CCR which will be presented by Dr. Sulagna and Dr. Rajat from our department, supported by the radiology department. This is a slightly unusual case of unknown poisoning, which was admitted to our ICU. And usually unknown poisoning are some organophosphorus poisoning or some alcohol poisoning, but this patient was unusual poisoning, and following further investigation of the elements, it was found out and treated accordingly. So now I request Dr. Rajat to give the presentation.
Good afternoon, everyone. Welcome to Clinical Combined Round from the Department of Anesthesiology, Pain Medicine and Critical Care. So, jumping straight into the case, we have a 28-year-old female by the name of Karishma, female resident of Delhi, who is housewife with no prior comorbidities, with presenting to AIIMS Emergency Department with chief complaints of alleged history of toilet cleaner congestion. So, coming to history of presenting illness, patient was apparently seen well at around 11 p.m. in the night by her husband and was brought to the emergency of AIIMS early in the morning around 4:30 a.m. with loss of consciousness and frothing from the mouth with a bottle of toilet cleaner lying near her. So in the primary survey, airway was threatened due to poor GCS. Breathing was intact with bilateral air entry present, and respiratory rate was 25 per minute, and room air saturation of around 92% with a gasping pattern. Circulation was all right with heart rate of 60 per minute and then BP of 126/80. GCS was even V1 M1 with bilateral pupils constricted. Hypothermia was prevented in exposure. So course in the emergency, patient was immediately intubated in view of threatened airway, and circulation was supported with fluids and vasopressors. After stabilization, because there was a bottle of toilet cleaner lying next to the patient, it was assumed that the patient had corrosive ingestion, and to work up for further, she was shifted to CT scan, where CT brain and CCT thorax and abdomen were done. NCT brain was done in view of loss of consciousness, which turned out to be normal, and CCT will be discussed further. Patient also had a toxidrome of cholinergic poisoning, which had like few elements like salivation was there, emesis was there, meiosis was there. Although lacrimation, urination, defecation and GI pain were not there. Patient was started on atropine because patient also had bradycardia, 60 per minute rate at presentation. After bolus, patient was started on with atropine infusion. Maximum dose of around 10 milligram per hour was given. So at presentation around 450, we can see the pH was 7.22, PCO2 was 56, BICAP was 14, which further dropped around 10 a.m. in the morning to 6.88, and BICAP was 15, and PCO2 had increased to PCO2 was 45, and again it was persistently same around 1 p.m. And patient's hemodynamic condition further worsened, and worsening acidosis. Plan for endoscopy from gastroenterology was deferred in view of instability, and patient was shifted directly to AV8 ICU. So coming to course in AV8 ICU, day 0 patient was shifted with atropine and noradrenaline infusion. Fluid resuscitation was continued in view of fluid responsiveness of the patient. Focus revealed that the lung had a bilateral A profile which was normal, and echo was normal with a IVC of 0.7 centimeter and collapsible IVC. DVT scan was normal, bilateral femoropopliteal vessels were compressible. Urine tox screen was negative. Nothing was detected. So patient had worsening acidosis, which was majorly non-anangap metabolic acidosis, probably related to corrosive ingestion. Nephrology SR was informed for an immediate dialysis because of low pH and low bicarbonate, and DLFC was inserted immediately, and patient was given a slot for dialysis, and 2.5 hours session of dialysis with nil ultrafiltrate was done. So we can see the pre-HT and post-HT ABG here. pH was around 7.18 and which improved to 7.43. BICAP from 16 has increased to 3.2. Whereas lactate remained the same with around 3.4 and 3.9. So investigations on day 0, patient had an elevated count of 32,000, predominantly neutrophilic, and rest of the investigations were normal. Mild transaminitis, and on day 1, patient had an increase of creat from 0.8 to 1.5, and the transaminitis persisted. Counts decreased from 32,000 to 5,000. So hemodynamically, patient worsened on day 1. NORAD had increased to 50 mics per minute, and vaso was going at around 2.4 units per hour. And USG abdomen was done to see if there was any other collections or any perforation, but it was fairly normal with only mild ascites, predominantly in the pelvic region. Patient was concomitantly started on hydrocortisone injection in view of worsening shock, and antibiotics were added, meropenem, in view of persistent shock. A trial of methylene blue was given to decrease vasopressor burden. 100 mg IV over 1 hour was given. Within the next 12 hours, vasopressor requirement successfully decreased and patient was weaned off vasopressors. Gastroenterology consult was sought again on day 2. It was again deferred, and management was continued on the same line. By the end of day 2, vasopressors were fully tapered off, and by day 2 evening, day 3 morning, it was planned for an SBT or SAT. Patient's GCS did not improve with stoppage of sedation, and pupils were still constricted. So it is very rare to see CNS involvement in corrosive poisoning. So that was one unusual finding in this case. So what we asked the attendant to bring the bottle with a compound which she had ingested. We tried to see if there were any other unusual constituents which were present in the compound. Unfortunately, the label did not give us any information regarding the constituents of the compound. So we tried calling the manufacturing company to see if they will help us with regard to any other compounds present or any other manufacturing processes which will help us. But the effort was fruitless, call was not picked up. So on day 3, CNS examination was done because of E4V1 M1 status. ONST was done, which was borderline with 0.52 and 0.55 centimeter. Cranial nerves examination, pupils was bilateral 2 mm and not reactive to light. Cough reflex was present. Sensory examination could not be performed. Motor examination, normal tone in all 4 limbs, and bilateral symmetrical reflexes in both upper limb and lower limbs. Fundus examination was within normal limits. So we tried to find any other cause for CNS involvement, if there were any other comorbidities or any other history which we can get. So we retook the history. There was no comorbidities, patient had no medication history, no personal history suggestive of anything. So with regards to history, there was no clue as to why patient had a E4M1 status with corrosive ingestion. So to further investigate the cause of CNS involvement, samples of blood, urine, and the compound which she had ingested was sent to ecotoxicology lab to see the constituents. Meanwhile, MRI brain was planned. So previously NCCT brain was done in emergency, which was normal. I now call Dr. Damini, Senior Resident Radiology, to discuss the radiological findings, both CCT, chest, thorax, and then MRI brain.
Good afternoon, everybody. So the patient underwent CCT chest and abdomen first, in which we can see that there is slight thickening of esophageal wall, circumferential edematous thickening of esophageal wall, as well as the stomach and jejunal loops. The jejunal loops, the stomach and the esophagus shows circumferential uniform thickening with maintained neural stratification, which is more consistent with inflammatory thickening of the bowel loop. Apart from that, we can also see some changes of aspiration with centrilobular nodules, peribronchial thickening, and areas of patchy consolidation, independent areas in the subpleural peripheral location. So continuing with the same, in this we can clearly see that the esophagus, mid and the distal esophagus had edematous thickening. The stomach was distended with edematous thickening and hyperenhancing mucosal wall, and the jejunal loops were also edematous and thickened. And MRI brain was done on 6th of July, which showed hyperintensity on T2 as well as on flare images within the corpus callosum, more on the splenium side. Same on DW images, we could see that the splenium showed diffusion restriction, and there were also a few microhemorrhages in the gray white matter junction in bilateral cerebral hemispheres. So this was consistent with cytotoxic lesions of the corpus callosum, which also is seen in toxic encephalopathy and more commonly involves the splenium of the corpus callosum. And the other findings are summarized here. So there was mid and distal esophageal edematous thickening with maintained mural stratification, and similar thickening was seen in gastric wall, duodenum, and jejunal loops. So this suggested inflammatory thickening because of the corrosive ingestion, and T2 flare hyperintensity in the corpus callosum with diffusion restriction predominantly involving the splenium, along with few microhemorrhages at gray white matter junction, which, as he summarized, was part of toxic encephalopathy.
So continuing with the case, again the CT was suggestive of corrosion, but again CNS involvement still cannot be explained. So course in A-bed ICU on day 4, patient had worsening PF ratio with fever, and lung ultrasound was suggestive of consolidation with dynamic air bronchograms. A diagnosis of VAP was made, cultures were sent which yielded Klebsiella pneumonia, which was sensitive to polymyxin, and antibiotics escalated for the same. So we had sent, before doing MRI, we had sent samples of blood and urine and the compound for analysis in echotoxicology lab. So which revealed very high levels of nickel in blood and urine. So that was a surprise for us. Patient had ingestion of corrosive agent, but it turned out to be a heavy metal in the blood and urine. So even the compound which she had ingested was sent for analysis, which revealed the same thing, which had very high levels of nickel in it. So patient had CNS involvement. So we wanted to see if it can be seen in CSF also, if there is brain involvement by nickel. So we sent CSF sample next day, which revealed that CSF also had very high levels of nickel. So here we can see methylene blue was given for shock on day 1. That day baseline blood nickel levels were 15.2 microgram per liter, but the reference range, normal reference range, is between 0.14 and 0.65. It is elevated by 15 times, and urine nickel again is 21. The reference range is less than 5.2. Tolerant renal had a levels of around 3,468 micrograms per liter. So we searched for literature as to what can we do with regards to acute nickel toxicity. There was no literature as to which said what can we do for acute, very minimal literature, whatever was there regarding acute nickel toxicity. Most of the literature was on chronic nickel toxicity, and the case was discussed with Dr. Javed, ecotoxicology lab assistant professor anatomy, and it was decided to give a trial of methylene blue for the treatment. A total of 3 doses of 100 mg methylene blue every day for 3 days was given. So we analyzed this blood and urine samples again before and after giving methylene blue. So we took the sample before giving the 3rd dose of methylene blue, which was around 7.4 microgram per liter, and after 3rd dose we had taken around 6 hours, 12 hours later, which decreased the blood levels. Urine nickel levels had increased significantly from 8.8 to 51.9, and CSF nickel levels, as I had told previously, was elevated at around 55.5. There is no reference range because no literature is there regarding CSF nickel levels, and definitely it is around 4 times higher when it is compared to blood. So from day 5 to day 8, patient had gradual improvement in GCS. Patient improved to E4 VT M6. From M1, she has improved to M6 48 hours after the 3rd dose of methylene blue. And chest X-ray also in the meanwhile had improved. There was a resolution of VAP. Fever spikes had come down. Patient was successfully extubated on day 8. So I now call Dr. Javed, assistant professor anatomy, to discuss regarding the role of methylene blue in nickel toxicity.
So I will be discussing about how we are analyzing heavy metal in all the body fluids, tissue, nail, hair, and apart from that, we will also discuss about how to collect sample, because multiple times the residents call that in which vial we have to collect. Sometimes they are collecting in EDTA vial, which is already contaminated with so many heavy metals because EDTA is there. So basically, we are quantifying all the heavy metals and other elements apart from heavy metals by ICP-MS, inductively coupled plasma mass spectroscopy, which is based on ionization of the metals at the plasma temperature. The temperature is surface of the sun, 6000 atoms are ionized at 6000 degrees C, and then it goes to the quad pole, and finally with the time of flight we are able to analyze up to PPT level. So for sample collection we used to provide metal free vials, and for hair and nail there are protocols that how to tag the nail and hair, and in this case we have collected this toilet cleaner, and it was very unusual finding, because the recommendation was for toxic screening in the blood and urine, and we have gone for all the volatile organic compounds, non-volatile organic compounds with the help of GCMS, the another technology we have for analysis of organic toxins, and it was totally negative for all those compounds. Then we thought that we should go for heavy metal screening, and then found that this nickel was exaggeratedly high. Then the problem was what, the patient was very sick, and it was difficult to go for the chelation therapy by the conventional method, that is Saximar and the EDTA, other methods are available, because what happens once we administer chelating agent, then what happens, the essential minerals, especially this copper and cobalt, is going significantly down actually. That may induce other health complications, and patient may become further sick. So therefore we discussed, we searched for too many literatures, and then we pointed that what treatment family is giving is actually appropriate, and we should go with this methylene blue. And we have seen the very significant report. It is first of its kind, I suppose, the treatment we have chosen for this nickel toxicity. So further elaboration. And another thing, that if the resident is sending sample for heavy metal screening, it is advisable to collect metal free vials from our facility, which is available with us. And for acute toxicity, blood, urine and other body fluid is fine. If we are trying to find some chronic toxicity, in that case it is better to go for the hair and nail analysis also. Thank you ma'am, will be continuing.
Thank you, Dr. Javed. So, when a patient comes with unknown poisoning, the initial approach should be stabilization of airway breathing circulation, and with proper physical history and examination, we should be able to identify a common toxic drone. If that is identifiable, the initial management should start in the lines of treating the toxic drone. Further, by diagnostic testing and specific treatment can be instituted. But the golden hours of resuscitation should focus on treating the toxic drone if it is identified. The common toxic drones are like the cholinergic toxic drone, the anticholinergic, the sedative, sympathomimetic, and opioid toxic drones. This patient had mainly meiosis, bradycardia, hypotension, also had increased GI secretions, and she presented with frothy secretions in the mouth. So it most common symptoms resemble cholinergic toxic drone. So nickel is an element naturally present in the soil, in the environment, in the groundwater, and also in the atmosphere. It is ingested through food and drinking water. It has low GI absorption, and it is present commonly in food like cereals, chocolates, and legumes. It can usually chronic nickel toxicity is reported. However, acute nickel toxicity, although rare, can happen due to parenteral Parenteral like institution of braces or any prosthesis mainly that has been reported. Inhalational, ingestional or dermal absorption. Nickel carbonyl is the most common compound that is implicated in acute toxicity, and the most common symptoms are the respiratory and the non-specific symptoms. Whereas chronic nickel toxicity can present as sinusitis, dermatitis, and occupational asthma. Respiratory symptoms are very common, and prolonged exposure has been reported to be associated with lung and nasal carcinoma. So, how does it? How does it harm? What is the mechanism of toxicity? A metal ion will. It usually metal ions like molybdenum, nickel, cadmium, they all bind to the thiol groups, the different active groups of the proteins, and they lead to increase in reactive oxygen species. So they denature the protein, they denature the DNA, and also lead to lipid peroxidation. This damages the cell membranes and leads to cellular swelling and edema, like cerebral edema or nephrotoxicity or toxicity in the lungs. So the common symptoms are respiratory and gastrointestinal in case of nickel. It is distributed in different organs like the liver, kidney, adrenal or the lungs. The diagnosis is mainly with the help of serum and urine samples. The average serum concentration is less than 0.3 micrograms per liter, whereas a very high concentration of urine nickel more than 10 micrograms per liter signifies severe exposure. Also, pneumonitis is the common presentation in acute as well as in chronic toxicity. Radiological presentations can include pleural effusion, irregular linear opacities, nodular mottling. Cardiac manifestations in the form of sinus tachycardia or STT changes signifies myocarditis. So the lines of treatment are first decontamination. Usually the exposure, the toxicity is due to inhalation or through skin absorption. So decontamination or removal from the environmental source. Supportive care, and urinary nickel is mainly excreted through the urinary route. So nickel basically the excretion can be increased by diuresis. However, hemodialysis is ineffective because nickel is highly bound to albumin, and the transport protein is nickeloplasmin, so it cannot be removed by hemodialysis. Chelation therapy has been proposed, like diethylcarbamate (DDC) or dimercarpol has been proposed as antidotes, but there is controversy regarding chelation therapy because these are mainly animal studies done in 1980s or 1990s, where rat models were treated with DDC, that is dimethyl carbamate. Okay, so in with immediate treatment in rats with DDC, there was reduction in mortality, but when DDC was given late, that at 6 hours there was no effect, and given at 24 hours the mortality was seen to be in fact increased. So also the DDC is not always available commonly. It is not available in US, it is not available in our scenario. The next best chelation therapy that is available is disulfiram. Actually, DDC is a active compound of disulfiram, but disulfiram can lead to increased CNS concentration of nickel in the brain. It cannot help in CNS excretion of nickel, and it has been shown to also increase mortality. The other options that have been found in the literature are dimercarpol and penicillamine, D-penicillamine. However, there is very limited data regarding their safety and efficacy, and they have been shown to be only partially effective in animal models. So, no society guidelines has recommended giving chelation therapy in acute nickel toxicity. The evidence is limited. So, what do we do now? In fact, when we searched the literature and when we were in such a dilemma as to what to do, with guidance of Dr. Javed, we found that actually nickel has been used, nickel nanoabsorbents have been used for industrial wastes to clear the dyes like methylene blue. So basically, as we can see here, yeah. So this is a nickel molybdenate compound. This is the molecule. So here, when it undergoes hydroxylation, there are two oxyl ions that open up. These are highly negatively charged ions, oxyl ions. So now they bind to the methylene blue molecule and they chelate it like this. So we actually thought that this was a retrospective hypothesis that as the patient immediately improved with methylene blue, the improvement was very abrupt. We thought that this methylene blue must have chelated the nickel, and therefore it has helped in excreting nickel from the brain and the blood. And also, but definitely this concept needs further exploration. So if we see here, nickel has a first order kinetics excretion. So if the blood concentration is high, the urine concentration will be correspondingly high. But as we see, after initiation of methylene blue therapy, the urine concentration kept on increasing, but the blood concentration was decreasing. So this is not just an incidental finding. This must have been due to methylene blue. This was not just a normal renal excretion of nickel. So some of the practical aspects that we thought about when giving methylene blue is that it is usually given in refractory vasoplegic shock. It is given in treatment of methemoglobinemia. The doses usually used are 2 milligrams per kg at a single dose, and it can be repeated. Higher doses have been used, but the important side effects that can happen with methylene blue are the hemolytic anemia, serotonin syndrome, and in fact methemoglobinemia. This is a paradox because methylene blue, when given in low doses, methylene blue with the help of NADPH can lead to reduction of the methemoglobin from Fe3 to Fe2. But when methylene blue is present in very high doses, because of depletion of NADPH, it can directly oxidize the Fe2 of the hemoglobin to Fe3 and produce methemoglobinemia. So the daily levels we measured. For this reason, we measured the daily levels of methylene blue, and the maximum reached was 5.5. This is well tolerated. Reports say that 10 to 20% of methylene blue methemoglobin levels are well tolerated. So definitely our treatment did not cause any significant side effects. So we conclude that this was probably the first case to report acute nickel toxicity mimicking as a cholinergic toxidrome after a toilet cleaner ingestion, and it highlights the importance of detecting unconventional agents for unknown poisoning. So we should not stop till we get a proper specific agent of toxicity. So therefore, comprehensive care with aggressive symptomatic management, considering unconventional treatment approaches and early diagnosis of toxicological samples of the samples for toxicological analysis can help us in tiding over such crises. Thank you. Any questions? Any questions? The patient got extubated at day 8 and went smiling from her eyes with preserved intact CNS.
Dr. Sulagna, very nicely managed. One very sorry on the Java is because we have seen not rare, but commonly we have seen toxic, not toxic, but chlorine infection in our cases with chlorine. They do not develop this. So this is particularly a company-related issue. What I want to mean is the normal component of
It depends on kind of toilet cleaners and companies also.
Right.
So nickels are being used as a germicide.
Okay.
So some of the companies they are adding nickel. Even it is in pesticides also, and it ruptures the gut of the paste and all. And nowadays it is being used as gems components.
But actually, it is found in industrial solvents. So, and many a times patients don't have any branded cleaners. Usually cleaners have phenols or inorganic acids, but the phenols can present like organ phosphorus toxicity, which this patient did not respond to atropine. So that's why.
Good afternoon, everybody. On behalf of the Department of Pediatric Surgery, I welcome you all once again to the second session of this CCR. It is indeed a coincidence that the first one was presented by anesthesia. It was about nickel poisoning, and we shall be discussing about glutaraldede. So the case for the Department of Anesthesia, the modality of poisoning was ingestion, and in our case, the patient came to the hospital and it was inadvertent instillation into the peritoneal cavity. The first poison was working from within the GIT, and this one is working from around the GIT. All the houses have toilet cleaners, and all the hospitals, all the facilities within the hospitals, they use glutaraldehyde. In fact, I'm sure all of us familiar with these pictures. So all of us are familiar with these bottles of glutaraldehyde. They are used inside the operation theaters. They are used in the endoscopy suits. The radiology people are using for cleaning the instruments using fluoroscopy. In fact, the common instruments like artery forceps and mosquitoes in the ward, they may also be sterilized before simple procedures like abscess drainage or catheterization is performed. So, why is it glutaraldehyde all around? Basically, glutaraldehyde is a cold sterilant. So, it offers the advantage of cleaning the instruments at the normal temperature. So, when we talk about surgery, we have a large number of instruments which are heat sensitive, like the endoscopes, the bronchoscopes, arthroscopes. Then some of them are sensitive because they are composed of plastic. We have rubber tubings and so on and so forth. So all these things, they are prevented from the heat shock which is offered by the autoclave. The autoclave not only just destroys the substance, it also loosens the bond by which the various parts of the scopes are held together. So herein lies the role of glutaraldehyde. Then over and above that, glutaraldehyde is a cheaper alternative, so it is used in the third world countries, and it offers sterilization in 20 minutes. That is what the traditional teaching is. So it can be used in high volume centers for rapid turnover between the cases. Chemically, it is a dialdehyde which alkylates the bonds in the microbe DNA, RNA and protein. So it is a very, very powerful microbicidal. It has tuberculocidal effects, virucidal, fungicidal as well as sporicidal. Now through the CCR, I wish to take you all through an undesirable sequence of events and the consequences which happened thereof. My team today comprises of my faculty colleague Dr. Anjan Dua, my senior residents Dr. Chandramouli, Dr. Kaushal. Then we have senior resident from radiology, Dr. Damini. We have Ms. Shivani, who is a research assistant on my team. And we were supposed to have a OT technician, Mr. Satya Prakash, but since the laparoscopic case is going on, he has not been able to. Thank you.
Okay. Our 2-year-old boy presented to us with impalpable undescended testis with grade 3 vesico-ureteric reflux with a history of repeated urinary tract infection with recent scarring in the upper pool of kidney. The child underwent cystoscopic Dexel injection and laparoscopic Fowler-Stephens stage 1 procedure. So the surgery was completed uneventfully. The child was also allowed orally on the same evening of surgery, and he passed stool next morning. Routinely, these patients are discharged within 24 to 48 hours of surgery. But this child had a deviation of the postoperative course. 24 hours of surgery, after surgery, the child started having abdominal distension with associated vomiting, which progressed to bilious vomiting and tachycardia, hypotension, with evolving into hypotensive hypovolemic shock. So these were our 3 concerns. The child was stabilized with a wide bore IV access, pumping out of crystalloids and colloids, making the child nil per oral, use of inotropes and strict monitoring.
An abdominal X-ray was performed in erect and supine position, and we can see that there are multiple dilated bowel loops both centrally and peripherally with air fluid levels with air fluid levels. So that suggests small and large bowel obstruction. And also we can see that there's paucity of bowel loops in the pelvis region with some mottled lucencies within the bowel loops in the pelvis. So this could be that there is large bowel obstruction, and apart from that there could be some collection or ascites as well.
So to rule out any possibility of iatrogenic cause, we reviewed the surgical video and there was no such etiology found. Ruling out other causes, we did a thorough search of the literature for similar kind of presentations. We had a discussion with the within the department, and the child was posted for exploratory laparatomy. The striking feature on opening the abdomen was this grossly edematous muscle wall, thickened muscle wall with trickling of fluid while opening. There was mild ascites with a straw-colored fluid which came out during opening the abdomen, but there was no feculent or bloody peritonitis. The involvement of the bowel was patchy with areas of khaki-colored thickened hard bowel alternating with areas of hyperemic thin bowel. Each segment was around 15 centimeter. However, the first 60 centimeter of the bowel was the small bowel was not involved. The entire small and the large bowel up to the peritoneal reflections were involved in a manner unrelatable to the common and known ailments. The infraumbilical parietal peritoneum was also hyperemic. There was mesenteric lymph nodes enlarged as well. However, there was no solid organ or hollow viscous injury. Reviewing the previous literature, there were similar cases mentioned with glutaraldehyd injury. So we did a thorough lavage with a large volume of saline and put 2 wide-bore abdominal drains which were placed in the lower abdomen for lavage in the postoperative period. In the postoperative period, we had a strict surveillance. Patient was on close monitoring of the vital parameters, and inotropes could be stopped by postoperative day 1. Continuous abdominal lavage from the drains were done till 48 hours of surgery. We were suspicious of that the bowel injury could lead to eminent perforation, but this did not happen. The abdominal wall edema settled by day 5 of surgery. Bowel sound was absent for quite a long time with high Ng output, and the child passed stool only on rectal stimulation. He could not be started orally early, so TPN was considered for nutrition. There was also no wound adhesions. Early ambulation was started. Regular parental counseling was done in view of the nature of the problem. Due to persistent high Ng output and inability to establish feeds early, the possibility of obstruction stricture was ruled out by contrast study. The child did have a prolonged hospital stay, but at the end, he was discharged in a stable condition. Now we are following him up for a period of 9 months. He is doing well, gaining weight, achieving milestone as per age, and with no residual sequelae.
So with this case fresh in our minds, a systematic review was conceived to gather the information and to make a systematic analysis of the mucosal injury and intraperitoneal injury due to glutaraldehyd. The systematic review was done in accordance with the PRISMA guidelines, and 34 papers were included finally, wherein both animal models and human studies both were included.
I will be discussing the animal studies. We identified 2 animal reports. Both of them were conducted on Sprague Dowley rats to study the adverse effect of glutaraldehyd. The first one was by Durante, which demonstrated the concentration-based damage upon intracolonic injection of glutaraldehyd. Clinical findings included crypt epithelium necrosis and neutrophilic infiltration. 6 out of 31 rats died, and 3 of them demonstrated hydrothorax and massively congested
lungs. In another study by Hutt et al., intraperitoneal effects of glutaraldehyde were studied during laparoscopic simulation. Adverse effects were displayed on omentum as well as the kidneys, and the adverse effects were compared against ethylene oxide as well.
Thirty papers were included in the human studies where proper sigmoid colonoscopy was done, and the earliest reports were dated back to 1986. One of the first case series was published in 1995, wherein there was a series of 6 patients with an outbreak of hemorrhagic proctocolitis over a period of 3 months, wherein proctosigmoid colonoscopy was done. There was no other apparent cause but close clustering of cases with a malfunction of automated instrument washer was seen to be the most common factor associated with hemorrhagic colitis. The patients most commonly presented with blood in stools, which was seen up to in up to 40% of the patients, whereas diarrhea, pain in abdomen, tenesmus were the other common symptoms. The patients also presented with constitutional symptoms. And apart from abdominal tenderness, there was no other clinical findings that were seen in these patients. Most of the patients usually presented in the first 48 hours, and the earliest presentation was within the first 2 hours after the procedure was done. To rule out any other cause of the hemorrhage, X-ray was done, which suggested no perforation in most of the cases. A repeat colonoscopy had got conspicuous findings in most of the patients, and the features were suggestive only of acute colitis with edema and inflammation of the mucosal bowel. Mucosal necrosis along with spasm of isolated segments of colon was seen in a few patients, and there was no specific findings on CT in most of the cases in these papers, but only irregular or heterogeneous circumferential colonic wall thickening was seen. Most of the changes were inconspicuous, and even the histopathological changes were consistent only with inflammation and necrosis. There were patients in which cryptic abscess formation was seen with or without necrosis. There is a varied presentation of hemorrhagic proctitis, but most of the patients reported were self-limiting. Yet there was one death in the entire series, which was a 70-year-old male patient who had got systemic lymphangioma with who expired due to a fulminant pseudomonas sepsis. Conservative management has been sought in most of the cases, and symptomatic treatment has been advised and done, and most of them have responded well, with only a few patients requiring steroid and mesalamine, which has not been evident.
Regarding the laparoscopic case report, 2 such case reports has been described. One of the case had very similar presentation with a child of undescended testes similarly who underwent laparoscopic orchidopexy. He had a documented spill of glutaraldehyde during carbon dioxide insufflation. Similarly, at 24 hours of surgery, the child had fever and abdominal distension followed by vomiting and shock. However, the child had on surgery, the child had several eschlerotic patches and had to be excised. The post-operative course was very stormy with sepsis. The child had formation of enteric fistula and enterocutaneous fistula, required a long-term total parenteral nutrition and multiple laparotomies. On the other side of the spectrum, a 36-year female underwent laparoscopic tubal ligation and was discharged uneventfully. However, during reviewing the surgical video, evidence of glutaraldehyde spill was documented. So the spectrum can be wide, ranging from no complications at all to a severely damaged bowel with so much morbidity. Our patient lies somewhere in between.
So at this juncture, one may argue that why we have attributed our case to glutaraldehyde when we didn't have any obvious record of spill or any histopathological evidence to support so. So, but it's the circumstantial evidence which surrounds this particular case. This case happened when there was a change of practice, brief period, when we moved from our main department to the mother and child facility, where the plasma sterilizer, which we normally use, that was on and off. I mean, it was there, we were using, but that particular day somehow the main reagent was not available. So we had to resort to using a tube, the insufflation tube. And if you would, I can explain it, it's a long tube with a very long dead space inside, intraluminal. What we assume would have happened is that it was put on inside X, and the main advice and the main thing that saves us is the irrigation, rinsing of the glutaraldehyde solution from all the instruments that we use otherwise. Here, possibly the intraluminal content or the glutaraldehyde was not properly rinsed and it was used, but that part would have been recorded. But the practice that we have, some of our surgeons have, we don't use a visiport and we don't use the insufflation, don't do it directly under vision. We first insert the tubing once the carpinoperitoneum is established, and then we put the telescope. Probably in those initial 3-4 seconds, there was aerosolized, the glutaraldehyde got aerosolized and got spread all over the peritoneum and the bowel wall, leading to edema and subsequent changes that we described. So one point just I want to refresh is that there are various percentages which have been described for proper sterilization to get the effect. Here for laparoscopy it is to be avoided. That is what I think Prabodh will also carry on with this. Prabodh, you may carry on. The general message what we get from this particular case.
This was a very stressful case for the department. We were seeing an ailing child, we were seeing the helpless patients, and we knew that the cause of the problems lies within the system. So that 1 month was very stressful and the outcomes were not clear. During that time, whatever we read, whatever we discussed, we realized one thing, that the staff in our institute, I mean the nursing staff and the technicians, we all know that Sidex can be used for this purpose, but we are largely ignorant about the possible adversities with the use of glutaraldehyde and how it is to be prevented from happening. Then one major flaw that we have been doing is we consider that soaking an instrument into glutaraldehyde for 20 minutes and then the traditional concentration of 2.4%. We believe that it helps with sterilization, which is absolutely wrong. So technically, when you dip a surgical instrument into 2.4% glutaraldehyde for 20 minutes, it affords only high level disinfection, which means that the instrument is fit for use for any procedure where the mucosal integrity is not being breached. So you can do an endoscopy, but you cannot do a laparoscopy. For sterilization, the recommendation is 3.4% and the time required is 10 hours. So it doesn't save time for high volume centers. But yes, we have been doing that, we have been carrying on with it. Then coming to the part, then what after an instrument has been soaked, or what if you are using glutaraldehyde and how to prevent such misfortune. So firstly, whenever an instrument is dipped into glutaraldehyde, it should be scrubbed clean of all the tissues. We should take care of the concentration, the time for which it is dipped, and the shelf life of the reagent. The reagent, generally the shelf life is around 14 days, but yes, it varies from manufacturer to manufacturer. Thirdly, when you take it out, it has to be rinsed. As per the standard instruction, it has to be rinsed at least thrice. We have to use volumes of water. So what they say is like use at least 2 gallons of water, which would be slightly less than 4 liters. But then for this suction, for this gas tubing which is used in laparoscopy, it is 3 meters long and it is an inner diameter of 1 centimeter, which means that the capacity is around 180 ml. So a tube which is completely dipped into glutaraldehyde is housing 180 ml of glutaraldehyde within itself. So once you want to use it, you have to ensure that the entire 180 ml is out of the tube. It's an oily liquid, it sticks to the walls. So you have to rinse it multiple times so that there is no residual glutaraldehyde. So besides rinsing, it has to be suspended vertically and then you have to dry it. Drying by air or vacuum is recommended, but drying by alcohol is not recommended because alcohol has fixative properties. And then glutaraldehyde is a double-edged sword. We have been talking about the patient so far. It harms us as well. It causes epidemic injury, it causes professional hazard. So it is known to cause bronchial asthma,
it can cause contact dermatitis, it can cause irritation to the eyes, nose and skin. In fact, the use of glutaraldehyde has been banned across many countries, but we still continue to use it because of the cheaper cost and maybe because of ignorance. So with this experience, the department first thought that it was a point that whether or not we should report this in literature. It can have medical legal concern, but we decided to report it in literature while curtailing the clinical details, so that especially the younger generations, the budding, the enthusiastic laparoscopic surgeons, they are made aware of such problems, because this is more common in the private sector. Secondly, we decided we should conduct a systematic review on this topic, so that because when we were struggling with this case, we realized there is no comprehensive source of literature. You will find a lot of material about the occupational hazard of glutaraldehyde, but for professional hazards, there is no comprehensive source. So that is why we went ahead with a systematic review. Then thirdly, within the department, we came up with this idea. So this is the classical tube on the left side, and on the right side now we are using a suction tubing. So we use the different parts that are available in the OT, and we connected a suction tube. The original tube cost somewhere around 6,000 to 40,000. But the suction tube will cost less than 1,000 rupees, and it need not to be reused. So you can use in every case and you can just throw it away. So this is disposable. So till the time that you are able to put the plasma sterilizer in place, we did around 230 cases with this setup, and all of them went fine. So this is how it is connected to the machine. Now we have organized a study, a pan-India study, and we are trying to, just like WHO has the surgical safety checklist, we are trying to make laparoscopic surgical safety checklist. And so it's a national initiative, and we have involved the pediatric surgery centers across the country, and we are working on that. So maybe by next year we'll have those guidelines in place. And finally, I think the most prudent decision would be to give up the use of Sidex in our hospital, in the hospital across the nation and globally completely. It is something which should not be used, because like if I look at my initiative, it's a very huge setup. We have so many technicians, we have so many hands working while the patient is being prepared, and everybody is busy. Nobody is watching what the other person is doing. Then we have the culture of contractual employees. They change every day. Even if they don't change, they are posted at different places. So somebody, if we try to train one person, then next day he changes. So I think with all the occupational professional hazard, we should give up with the use of glutaraldehyde. Thank you very much.
Please 30 years of experience. How many such incidents are recorded and monitored? Because saying that all the pediatric centers happens around the medical district.
So,
one instance.
Sir, it's not about one incident. I agree, one incident doesn't make guidelines, but we identified around 36 reports around literature. In all the included cases, if you add on to the cases altogether, so these cases sum up to like 1600 something, 1675 or something like that. Most of the cases, maximum cases have been reported while glutaraldehyde was being used by the gastroenterologist for proctocolonoscopy, different procedures. There are a known case of colitis, but those cases are self-limited. In fact, only a single mortality has been reported. Now it's up to us, you can say a single mortality or only a single mortality. Yes, sir. So,
how do you put those just show that profession or rather than glutaraldehyde? I don't think so that glutaraldehyde itself will cause bowel. Only 14 must have caused that. We have also seen that's call it chemical peritonitis.
chemical peritonitis, yes, sir.
Must have seen one or two cases. We have re-explored them, did a lab and came out in the patient center. But saying all will be Sidex, I think that is going too far.
Sir, in our case, it was a pan-bowel involvement.
Not your case, but
I think very interesting case presented, and very happy that we have tried to modify the future management of these based on experience. It has been used, say, in 1990s, routinely for all laparoscopic. But now, I don't think Sidex can be considered as the standard of care for stabilizing laparoscopic instruments. You have many things available. You have plasma stabilization. One problem with sided which are eliminated is this we had seen not only with sided but even with carbon dioxide. Carbon dioxide which is used during laparoscopy is a industrial carbon dioxide. It is not a medical carbon dioxide. When you connect it to a filter through which only the big particles comes from the bacteria. The other thing which can happen when you use sideds is tuberculosis. Like there are institutions which have reported like 6 cases of tuberculosis, 10 cases following that. And all of them, when you look into it, it was because they used instruments which were with sideds. So, one thing is that sideds sterilized instruments should never be used for. Second most important thing is when you are using sideds inside the instrument, it is a telescope, it is a camera, they have to be washed properly with sand. Okay, and this we can't blame it on the contractual employees or responsibilities of us. So in any institution, this will be called as a sentinel event. The sentinel event is an event which needs to be employed by the hospital. So I'm very happy that you have presented this case and you have tried to make modifications. But as the problem is in institute, everybody wants to increase numbers, including the administration. Anesthesiology is where they can launch. Everybody wants to do more and more number of cases. So we are trying to pack corners to do more cases. So I think we have to resist that temptation or the force of what people are asking you to do. Do something according to the standard. And the standard of the care is to use autoclave instruments. Use autoclave instruments. Do one case less. But do it properly, do it according to the standards. You don't use sideds at all. See,
We are not using it.
ensure that they're
Even
thoroughly
we are not using it anymore.
To that particular day, I hope that particular day was taken and the variant was not available. So that was possibly not a reason enough to cancel that case because I don't know, actually agree.
The pura pan bubble.
all of us do the best interest of the patient and we work to the best of ability. But unfortunately, we are cutting corners too many times and too much. And that is causing most of our problems which are facing in the institute. Otherwise, in the institute, the amount of commitment which is shown, I don't think anywhere in the world you can get this sort of commitment. The problem is, we are trying to cut corners too much and too frequent.
In ANOT, I remember in olden days, the system will not give you the instrument till it is 60 minutes in the side. Whatever you may tell her, she will not give you the laparoscopic instrument before it is 60 minutes in the side. Then the lecturer says 45 minutes in the side, fully due to instrument. That was the recommendation as far as I remember. So we only get some. And most thorough will slide there. Have saline in it, and they take those instruments into those saline. After they take out from that, then also they will pour that distilled water actually to distilled water. So if they have to pour the distilled water on those instruments again before we take it. The system would never allow the instruments to take out.
You are studying only pseudoscientists of the entire world. I don't think this is.
Yeah, it is pseudoscientists. It's only pseudoscientists. It is pseudoscientists on this.
That was against the important university. Possibly they undergo unreported. So the environment. I have seen functions cases of that's what I'm saying. They're not available in literature. But that was all circumstantial. Yes, that was all I told. There is no other injury, there is nothing. So the inflammation is because of that is the only thing which is there. So we really don't know that whether it was the sided which was there.
So, in our case, it was a pan bowel involvement, so we can't consider a cautery injury. It is serositis, yes, definitely. The problem with the gas tubing is it has a large volume inside. So, a simple flush, simply dipping it into a tray of water will not work. That is the main thing.
सर हमारे भी करते हैं इसलिए सारे केस में नहीं होता है सर. इट हैपेंड इन वन केस बट देन समथिंग हैपेंड सो इट हैज टू बी टेकन केयर. यस सर.
Be very careful. Like what? I'm not trying to say that you are married or saying is let us resolve that we will not have problems.
Yes, that's right.
But one more most important.
Which on the interpreter see that the gas comes out, no button, no saline, nothing comes out.
Then we connect to the flow.
That is a normal and standard teaching. Yes. So that has to be ensured.
Thank you.